So we'll see what we are going to learn in this case. Okay. So see, like you had your in the biopsy, he has 3 polyps, a large tumor. Okay, so we different terminology like polyps, adenoma, their pathological features. Okay, then he was having a poor diet. Okay, which is less of fruits and vegetable, and his daughter is forcing him to take more fruits and vegetable. Okay, so we'll see the how what are the effects of lifestyle like diet, exercise, the alcohol and smoking on risk of colorectal carcinoma. Then, as we discussed in the previous lecture, cancer is a genetic disease. So here we go to the genetic basis more specifically for the colorectal carcinoma. Okay, and both type of the cancer, sporadic and the inherited cancer. We also demonstrate the knowledge of something. What do you mean by the carcinoma in situ and the malignant tumors of the lower GIT? Okay, and features of the benign and malignant tumors of the GIT. So you see the features of the benign and malignant tumors of the colon, and what are different terminologies, what is the etiologenesis and what is the genetic mechanism. So what is polyp? Polyps or polypoid lesions are the inflammatory masses or tumors. It could be inflammatory or it could be a neoplastic. Okay, arising from the submucosa or muscle coat, but also protruding into the lumen. Okay, so these polyp, they arise from a surface, like in case of GIT, it has either from the submucosa or the muscle, and they protrude into the lumen as a finger-like projection. So these are the polyps. When you see something protruding into the lumen like a finger-like projections, we call it as a polyp. And it could be a inflammatory or it could be a neoplastic. This can only be tell by the histopathological examination of that polyp. Polyposis, when we call it polyposis, when there is a multiple polyps. And polyposis syndrome, when we see it is hereditary and characterized by a presence of multiple pedunculated. What do you mean pedunculated and sessile? Pedunculated means the polyp which has a stalk, which has like a good supporting, like a tree, which has a bark and the leaves, good supporting structure, or sessile, which doesn't have any supporting structure, just protrude into the lumen. So you see in the polyposis syndrome, multiple, more than 100 polyps, which could be pedunculated or sessile. It could be benign or malignant in the mucosa of an intestine. So this is polyposis and polyposis syndrome. So common types of the colonic polyps and the masses. We have non-neoplastic and the neoplastic. As we discussed, it could be a inflammatory or it could be a neoplastic. In the neoplastic, again, we will have benign and malignant. In the non-neoplastic, we have different types. Okay, hyperplastic, inflammatory, juvenile, and Peutz-Jeghers type of polyps. Hyperplastic, inflammatory, juvenile, Peutz-Jeghers. Neoplastic could be benign, adenomas, malignant, adenocarcinoma, and other tumor can also present as a polyp like lymphomas of the intestine, gist of the intestine, lipoma, any tumor which is in the intestine, leiomyoma is protruding in the lumen, we call it as a polyp. Okay. So this classification is clear for you all?
Yes. Yeah, doctor.
Okay,
Yes.
good. So here we are going to talk about two very common type of non-neoplastic polyp. Hyperplastic polyp and the Peutz-Jeghers polyp. Hyperplastic, asymptomatic, more than 50% are located in the rectosigmoid, 20% in the ascending colon. Okay, so it's more common on the left side than the right side. They are smooth, moist, round, small, around 0.5 centimeter, sessile lesion. They don't have a stalk. They just see the small protrusion into the mucosa. A non-neoplastic polyp, hyperplastic, can be multiple. Okay. And histologically, when you see, it is composed of the well-formed gland and crypts lined by differentiated globulate or absorptive cells. Pure hyperplastic polyps have no malignant potential. So these hyperplastic polyp cannot get transformed into the malignant one. Asymptomatic, more common in the left side than the right side of the colon. On gross or in the or the endoscopic examination, they look smooth, moist, round. They are small in size. They could be multiple. And histologically, you see just well-formed glands and crypt, and they are more in number. That's why it is called hyperplastic. Puigakers are the hamartomatous type of polyp. Okay, what do you mean by hamartomatous? They, along with the intestinal structure, they will have other structure in the polyp like muscles, fat, cartilage. That's why they call it as the hamartomatous polyp. It is a syndrome. It is associated with the syndrome. So you might see the pigmented lesion around the mouth, oral mucosa, face, or around the genitalia. It is rare and it has an autosomal dominant type of inheritance. It is caused by germline mutation in the LKB1 gene, which encodes a serine threonine kinase. Okay, as serine threonine kinase gene, and it is a germline mutation, autosomal type 1. Okay, so autosomal dominant. Okay, not the recessive. Okay, and these polyps are large and tend to be pedunculated. They occur anywhere in the GI tract from mouth to the rectum, and these patients have increased risk of developing another carcinoma, not the carcinoma in the polyp itself, where in the pancreas, breast, lung, ovary, and the uterus. But the polyps in the intestine or GIT are non-neoplastic. So what you have to remember, the type over here, it is the hamartomatous type. Okay, they have mucosal pigmentation around the face, lips, genitalia. Their way of inheritance is autosomal dominant. They are large, pedunculated, okay, and increased risk of cancer in other organ, not in the same polyp. So the pictures for this polyp, inshallah, you will be see you in the practical slides, okay. Now we go to the neoplastic polyp. So benign one are the adenomas, adenomatous polyp. It is seen mainly in the large intestine, 20 to 30% before the age of 40 and 50% after the age of 60. Males and females are equally affected. It has sporadic and familial both. They could be small pedunculated to the large sessile, and they are as a result of the epithelial proliferation from hyperplasia to adenoma, and they might show dysplasia, and if the dysplasia is severe one, they can transform into the carcinoma. You divide adenoma in the three types. Tubular adenoma, when they are mostly the tubule formation, you don't see the villi. If you see the villi, they are less than 25%. Villus adenoma, where you see the villus architecture more than 50% of the tumor or polyp. Tubulovillus, it is mixed. So now we go to the tubular adenoma. It is 70%, 75% type of the all neoplastic polyp. Okay, so if you call which is the most common neoplastic polyp, it is tubular adenoma. It can occur sporadically as well as well-defined hereditary syndrome. Around average age is around 60 years of age, and it occurs again, it is more common in the left side, distal colon and the rectum. It is usually single but can be multiple. Its size can vary from few millimeter to the many centimeter. If it bigger, will have a stalk. And what is a stalk? Usually stalk will be the central fibrovascular core. Here you see the sessile polyp. You just see a protrusion without any stalk. Okay. In the histopathology, it is a tubular adenoma which is showing a stalk. It might show dysplasia from mild, moderate to severe, and it might can turn into the malignant one, a carcinoma. Villus adenoma, it is the least common, okay, and it can be the largest and the most ominous of the epithelial polyp, okay. It can grow up to the 10 centimeter. Age is around 60 to 65. Male, female equally affected. It can present with the rectal bleeding, anemia. The features will be similar to the carcinoma. Person might complain of the bleeding. He might have the iron deficiency, anemia, okay, or sometimes they might have the large amount of the mucus secretion, so mucinous diarrhea. It is again more common in the rectosigmoid area. Its size from 1 to 10 centimeter. It is sessile. It is like a velvety, like lot of villi accumulated at one place, okay. And the microscopy, you see the frond like villus architecture. It has dysplasia from mild to moderate to severe and a 40% risk of the development of the carcinoma. Tubulovillous adenoma is combination of these both. Now, relationship of these neoplastic polyp and their development of the carcinoma. So initially these polyps are the benign one, but there are few features in this polyp with that you can like presume that there are high chances of development of carcinoma in this polyp. What are these features, okay? Or what are the probabilities? The most important is the size of the polyp. Bigger the size, there are high chances of development of carcinoma in that. The relationship of the villus feature. More villus architecture, more chances of the development of carcinoma. And the presence of atypia or dysplasia. More the severe dysplasia, more chances of development of the carcinoma. Initially, they used to say the villus feature and the dysplasia is the most important feature. It can turn into the malignant one or carcinoma. But nowadays, the size is the most important characteristic. And someone says if a polyp is more than 2 centimeter, there are like 90% chances of it will turn out to be the carcinoma if you will not treat it. So if you see a large polyp, do not leave it. Do a simple excision, take out the polyp, and you can make your patient less development of the carcinoma. But if you keep it over there, there are high chances of development of the carcinoma. So this point is very clear to you. All these three are risk of development of the carcinoma, but the size is the most important. Now we go to the familial polyposis syndrome. In this, patients have genetic tendencies to develop neoplastic polyps. They are mostly autosomal dominant, and these polyps from benign, initially they are benign, but very rapidly they get changed into the malignant one. Okay, so what is this one? Familial polyposis coli. It is FPCC. You see innumerable polyps in the colon. Sometimes the entire colon is full with the polyp, 500 to 2500. You might see the polyps elsewhere in the small intestine, stomach, esophagus, and the most of the polyps are the tubular adenoma, but there are high chances they might develop into the adenocarcinoma. Gardner syndrome is also, you see multiple polyps in the colon, And the associated malignancies along with this over here are the multiple osteomas, benign tumor of the bone, epidermal cyst, and fibromatosis. Turcot syndrome also you see the multiple polyps in the coli, gliomas, and the fibroma. But remember, in the familial polyposis coli, you see the polyps more than 100 in number. While here, there will be multiple, but they are less in number than the familial polyposis coli. And these two syndromes also associated with the other malignancies like osteomas, epidermal cysts, fibromatosis. Here you have there the gliomas, the brain tumors, and the fibromatosis. Now come to the familial adenomatous polyposis. What is this? It is an autosomal dominant disorder, genetic defect in the chromosome 5, short arm 21. Patient develops hundreds of colon adenomas from birth to the teenage. Affected gene is known as adenomatous polyposis coli or APC gene. You need to have minimum 100 polyps for a diagnosis of APP. Okay. Colorectal carcinoma develop in 100% of untreated FEP patient often before the age of 30. If you do not diagnose earlier, if you do not treat earlier, there are high chances of high or 100% chances of development of colorectal carcinoma. And the if you see the multiple polyps in a segment of colon, the prophylactic colectomy is the standard therapy. You see segment of colon, say like 20 inches of the colon shows polyposis coli. Take out that area from the body and keep the following of your patient. So this is how they look. There are multiple polyps, few are bigger, majority of them are tubular adenoma. Okay. Now we go to the neoplastic polyp colorectal adenocarcinoma, CRC. Epidemiology, colorectal carcinoma is responsible nearly 10% of the all cancer death worldwide. CRC is the third leading cancer in men and the second leading cancer in the women throughout the world. CRC is the second most common cancer after breast cancer in the general Saudi population. Okay, if you look general Saudi population, the most common is the breast cancer, second is the colorectal cancer. In the Medina region, CRC is the number one cancer in the men and the third most common cancer in the women after breast and thyroid cancer. Colorectal cancer incidence peaks at the 60 to 70 years of their age. Our patient was also 65 years out of age. And fewer than 20% of the cases can be seen age less than 50 years. So this is the epidemiology. Look at how the epidemiology has been different from the other world. In the Saudi, it is second most common, while it is third in other countries. And this is why, because there is a dramatic change in the dietary pattern of the Saudi population over a period of 50 to 100 years of age. Nowadays, Saudi people don't follow their traditional diet. Our diet over here is mostly the westernized diet. And the diet play a very, very important role in the development of the carcinoma. And this is our own study from the Medina region. And the CRC is the number one cancer in the men and the third number cancer in the female. So the risk factor, the dietary factors most closely associated with the increased colorectal cancer rates. And what is the most common dietary risk factor is the low intake of the unabsorbable vegetable fiber and high intake of refined carbohydrates of the fat. So you don't take most vegetables and the salads, and this our diet is mainly about the pastries, cake, donuts, ice creams, burgers, fries. Okay, so these are all are very high in saturated fats and the refined carbohydrates and very low in the vegetable fiber. So reduced fiber content leads to the decreased stool bulk. If you don't take fiber, the stool will not form in the bulk. And also they alter the composition of the normal flora of the intestine. If the stool is not formed in the bulk, there will be less defecation reflex. So the stool will remain for a longer period of time in the intestine. And you know the stool has all the discarded material, all the dangerous particle which cannot be absorbed. So these like dangerous or harmful material will remain for a longer period of time in contact with your intestine. And there are high chances of exposure to this unharmful material, and there is least normal microbiotic flora. All put together will increases the chances of development of the cancer carcinoma. Then family history of CRC, cancer of ovaries, endometrium and breast in women also make them higher risk of development of carcinoma. Genetic factor like FAPC, HNPCC, diabetes, hypertension, and obesity. These also play a very significant role in the development of the colorectal carcinoma. Why diabetes, hypertension, and obesity? Because these are the diseases which are again related to the dietary habits. So they have also increased risk of the colorectal carcinoma. If someone is having inflammatory bowel diseases, especially the ulcerative colitis, they also have high chances of development of colorectal carcinoma. Someone has exposure to the radiation for other cancers such as ovarian or prostate cancer, they also have high chances of development of colorectal carcinoma. COX-2 is an enzyme, okay? And these COX-2 convert prostaglandin E2, and these prostaglandin E2 promotes epithelial proliferation. So they say like COX-2 inhibitor such as the NSAIDs drugs like aspirin and other NSAIDs have protective effect against colorectal carcinoma. So if you can identify any person who are at high risk of development of colorectal carcinoma, you can give them aspirin as a prophylaxis to reduce the risk of development of the colorectal carcinoma. So here you understood well about the risk factor and their association with the colorectal carcinoma. Yes?
Doctor, can you explain
Yes.
the last point?
Yes. See, this enzyme is located throughout the body. They are located in the intestine also. So this cyclooxygenase 2 enzyme convert various things. I suppose you have certain things like thromboxane or something in the body, they convert to the prostaglandin E2. When these prostaglandin E2 forms in the intestine, they promotes epithelial proliferation like hyperplasia, adenoma, and dysplasia. So we have the drugs which inhibit these enzymes. And what are these drugs? These are the non-steroidal anti-inflammatory drugs, NSAIDs. They inhibit these enzymes. So this enzyme get inhibited. So there is no formation of prostaglandin E2 and there is no epithelial proliferation. So that we can give them aspirin or other COX-2 inhibitor as a prophylaxis. Clear?
Yes, doctor.
Okay. Now we go to the molecular pathogenesis. Okay. So there are two molecular pathogenesis. One is the adenoma carcinoma sequence and another one is the microsatellite instability. So we go to the adenoma carcinoma sequence. 70 to 90%. See, a larger number of colorectal carcinoma arises from the adenomatous polyp. They usually have hyperplasia, adenoma, and they go into formation of carcinoma. This adenoma carcinoma sequence is multi-step and they are very well researched and documented, and the roles of each and every gene is very well researched and explained. Okay, so there is a sequential mutation or deletion of the genes. And polyp with tubular histological pattern have the least malignant potential, whereas the villous adenomatous polyp have the highest malignant potential. Okay, this is the histological. Okay, but as we know, the larger polyp, the size is the very, very important criteria to develop malignancy. Okay, so if a tumor is more than 2 centimeter in diameter, there is a greater risk of cancer. Okay, so a polyp, a adenoma, benign polyp with the help of adenoma carcinoma sequence or multi-step carcinogenesis can turn into the malignant adenocarcinoma. So what happened over here? There is a normal epithelium. There is genetic like loss of mutation of APC gene. There is hyperproliferative epithelium. There is loss of DNA methylation genes. It will lead to the early adenoma formation. There is mutation of RAS gene on chromosome 12. There is intermediate adenoma. There is a loss of tumor suppressor gene. See, tumor suppressor gene is located on the chromosome 17. Okay, not the 18. Okay, so this is a wrong information over here. So there is late adenoma. There is also loss of tumor suppression gene on the chromosome 17. So there is a full-blown carcinoma. Okay. So this is called adenoma carcinoma sequence, and this is the molecular changes occurring at a different level. How a normal epithelium with the help of these molecular variation can develop into the carcinoma. And this carcinoma, again with the another set of genes, can go into the infiltration or invasion and metastasis. So here you have normal colonic epithelium, mucosa, submucosa, and the muscularis. So there is mutation of APC, loss of one allele. Okay, it could be germline or somatic. Okay, this is known as the first hit. So these mucosa become at risk. There is methylation abnormalities, inactivation of the normal allele, the second hit, loss of APC, both allele, okay, or beta catenin pathway. So there is a formation of adenoma. Then comes activation of oncogene KRAS, okay. So there is formation of an adenoma. Then there is loss of P53, wild P53. There is a more bigger adenoma with dysplasia, or there is development of carcinoma with metastasis and infiltration. So this is multi-step APC pathway adenoma carcinoma sequence. Now the second molecular mechanism, which is less common than the adenoma carcinoma sequence, is the microsatellite instability. Microsatellite instability is the molecular signature of the defective DNA mismatch repair gene. So this happen mainly in the DNA mismatch repair mechanism. Okay, and these are the mostly in the non-coding regions. So the gene get mutated and these non-coding regions become coding and they go into the formation of tumor. So what happened over here? There is a mismatch repair. So a DNA insert a wrong base in the newly synthesized DNA. So there is a mismatch repair. You got a wrong DNA codon here. This is a mutation. There is a mismatch repair. The cells has become abnormal and it will go into the proliferation. And these are the genes. MMR genes, primarily MSH1 and MLH, are found in the sporadic, while sorry. So these mismatch repair genes are found in the sporadic as well as familial hereditary non-polyposis colorectal carcinoma, which is known as HNPCC, while APC gene or beta catenin pathway in the APC pathway, while MSI principally associated with the MMR gene and seen in the HNPCC. So 10 to 15% of the sporadic diseases are due to the DNA mismatch repair gene. Okay. So these DNA mismatch repair gene pathway defectively repair the DNA. They insert a wrong DNA in a normal DNA and you get the different type of carcinomas. Especially these are the genes MSH2, MSH6 and MLH1 give rise to hereditary non-polyposis carcinoma HNPCC. While MLH1 gene is commonly involved in the sporadic coronal cancer due to satellite in microsatellite instability. Okay, so this is important. Sometimes they might ask about the gene. What are the gene are involved in the hereditary non-polyposis carcinoma due to inherited mutation? So due to inherited mutation are MSH2, MSH1 and MLH1. Okay. While the sporadic type of colon carcinoma due to microsatellite instability, the gene is MLH1. This is something difficult but very, very important to remember. Inherited mutation of HNPCC, MSH2 and MSH6. Sporadic mutation of microsatellite instability, MLH1. Okay. So this is MMR pathway. You have normal colon, mutation in MMR gene, MSH2 or MLH1. This will lead to the sessile serrated adenoma. There is another loss of TGF beta, BAX, BRAF, P53, and it goes into the mutation. So this is adenoma carcinoma sequence in the MMR pathway. Now we see the pattern of sporadic and familial colorectal carcinoma. Okay, so we have here the hereditary and the sporadic, and this is the molecular defect. Hereditary familial adenomatous polyposis syndrome, you have APCWNT pathway. If the affected gene is the adenomatous polyposis coli gene, and you see the hundreds of adenomas and carcinoma in the colon. Okay. Hereditary non-polyposis colorectal carcinoma. In the hereditary or inherited pattern, you have DNA mismatch repair, and the what are the gene affected here? MSH2, MSH6. They have adenoma and mucinous carcinoma. There will be polyp, but they are less in number, not as common as the HNP, APC type. Okay, like the sporadic colon cancer, these also affect most commonly APCW anti pathway, and here you see the left-sided adenocarcinoma. While sporadic colon cancer due to DNA mismatch repair gene, the gene involved MLH1 gene, and here you see the right-sided adenocarcinoma, and mostly these carcinoma are the mucinous one. Understood?
Doctor, I have
Yes.
Yes.
MH1, it's both in the sporadic and hereditary carcinoma will be
See, it can be both.
in the
You can
DNA.
also find these genes over here, but the most common one, MSH2 and MSH6, are hereditary non-polyposis inherited HNPCC syndrome, while MLH1 is the same pathway, MSI microsatellite instability pathway, DNA mismatch repair gene is associated with the sporadic colon cancer. So this is the gene. When comes the sporadic, you look for the MLH1. When come the hereditary, you look these two, MSH2 and MSH6.
Okay, thank
Okay.
you, Doctor.
Yeah.
Yes.
Any other question? Okay, so I'll move for the other. Okay. The genetic pathways of colorectal carcinoma, either hereditary or sporadic. Okay, either hereditary or sporadic. More common is the APC beta category in both hereditary and the sporadic. Okay, while the microsatellite stability is least common. Here, the defect in DNA mismatch repair gene, if there is like a gene MSH2, MSH6, you have hereditary NPCC. While you have the MLH1, it is sporadic one. So difference between familial adenomatous polyposis and HNPCC, here 100% are affected by 35 years. There are hundreds and thousands of polyps in colon. Mutation in APC gene accounts for 80 to 90% of colon cancer. Other cancer risks are the duodenal and the gastric. HNPCC, 80% lifetime risk, less than 10 polyps found. At least 5 genes. The most common, you remember the 3, MSH2, MHS6, and MLH1 in the sporadic. It is up to 10 to 15% of the colon cancer. Other cancer associated with the endometrial, ovarian, and the gastric. Now, risk categorization. When do you call it? Is a low risk, low moderate risk, high moderate risk, and the high risk. So low risk, only the one first degree relative with colorectal carcinoma at more than 45 years. Here, you don't need screening. Only you ask your patient for the bowel awareness, anything he noticed about abnormal bowel movement, or like alternate diarrhea, constipation, some bleeding per rectum, or some like anything bowel abnormality, he should report immediately. Low moderate risk are 2 family first degree relative with CRC at average more than 60 years of age. Here you need to have the screening, 1 colonoscopy at 35 to 40 year and 1 at 55 year in the patient. Suppose a person who has 2 first degree relative, okay, with CRC, like brother, sister, father, mother, okay. So, and it is more than 60 years of age, you need to have colonoscopy for your patient. You might find some difference of the screening age in this lecture and the surgery lecture. Mine is from the recent references. Surgery has, I think they have not changed it. Then high risk, 1 first degree relative of the CRC less than 45 years old, or 3 older first degree relative is more than 50. Screening you should start at 45 or 5 years prior to the youngest diagnosis. Okay, suppose your patient has got at the age of 40 years, you should do it 35 years, but not prior to the 35 years. And you repeat the colonoscopy every 5 years up to your patient turns to the 75 years of the age. Okay, so you got the low risk, moderate risk, and the high risk. Low risk is the first degree more than 1 for FDR, CRC at more than 45 years age. You don't need any screening over here. You just ask your patient for the bowel in. Low risk or moderate risk is 2 first degree more than 60 years of the age. Here you have 1 colonoscopy at 35 to 40 and another at 55 years. High risk, 1 first degree less than 45 years or 3 first degree at more than 50 years. Here you need to do the screening 5 years prior to the youngest age when you develop, and you keep on doing every 5 years up to the 75 years of the age. So how do you screen? Preferred method of screening is colonoscopy. And there are evidences which have suggested that colonoscopy screening have reduced the risk of CRC in the high risk group. So if you have HNPCC, colonoscopies from 25 year continue 2 yearly to 75 years of the age. If you have a documented cases of the HNPCC, you do the colonoscopy from the age of 25 years, do every 2 yearly for the 75 years. You also have to do endometrial and ovarian screening every yearly from 35 years. If you have a documented case of familial adenomatous polyposis, you have to start colonoscopy from the teens or even younger, depending upon the family history. You always offer do the prophylactic colectomy. You take out the affected area of the colon. Upper GI screening also you do the, because there are high chances of the intestinal and the gastric carcinoma also. So you do the annually upper GI screening. And you also put your patient on aspirin or COX-2 inhibitor as a prophylactic matter. Now the pathological feature of the colorectal neoplasm. Adenoma, they could be sessile or they could be pedunculated. Microscopic could be tubular, villous, tubulovillous or serrated. Carcinoma usually large, ulcerated, exophytic, big polyp, a big ulcer, areas of hemorrhage, necrosis, or you might see the annular. Annular means encircling the entire loop of the colon and causing an obstruction. Type adenocarcinoma, mucinous adenocarcinoma, signatrium adenocarcinoma, or squamous cell carcinoma. Adenocarcinoma, it is well the tumor have the architecture of the gland. It looks like a normal glands of the colon. Mucinous carcinoma, when the tumor produce large amount of the mucin, both inside as well as outside the glands. You see the glands, malignant tumor cells or the glands floating in the pool of mucin. Signatrial carcinoma, here there is principally intracellular accumulation of the mucin. So there is a large accumulation of the mucin inside the cell that push the nucleus at the periphery. It looked like as a ring with a diamond at a periphery. Squamous cell carcinoma usually you see in the anal region, because you know the lining of the anus, uh, inner is glandular, while the outer is the squamous epithelium. Morphology, you have to look for the practical session for the more details. Okay. 60 to 70% of the colorectal carcinoma in the rectum, rectosigmoid, and the sigmoid. The left side. Why the left side? Just think logically, because the majority bulk of the stool stay in the left side. And they stay for a longer period of time. You know, in your defecation lecture, for when you learn about the physiology of the defecation, see the bulk of the stool when formed, it stay in the sigmoid, and when there is a gastrocolic reflex or defecation reflex, it passes throughout. So that's why majority of this, there are high exposure of the dangerous or the unabsorbed nutrients from the stool to the colonic mucosa. So that's why high tumors on the left side. Left-sided carcinoma tend to be annular because the thick or like the solid consistency of the stool. So it's present through encircling the lumen. So tumor also encircle the entire loop of the rectum or sigmoid, and they have always present with the early symptom of the obstruction. Neoplasm starts superficially in the mucosa and slowly goes into the deeper layer, ulceration, infiltration, and eventually to the metastasis. So this is a tumor in which side of the colon, right or left?
Left.
Look carefully.
It is right in the second.
Right. Why it is right?
The cecum and the ileum in the left, in the
Yes,
right
you
side,
can
doctor.
see the cecum, you see the ileum, okay, and you see the mucosal hostration in the ascending colon. So right side. Right side tumor is usually large, ulcerated, and it has like for fungated polypoidal mass, okay, and it does not have any symptoms at the beginning because tumor take a time to grow. So that's why they don't. But the left side will have early symptoms due to the obstruction and the encircling nature of the tumor. So right-sided carcinoma tend to grow as polypoid fungating masses. Obstruction is less common. Invasion of the wall and extend to the mesentery, regional lymph nodes, and more distal site. Mucinous adenocarcinoma secrete abundant mucin that may go into the walls through the crypt or the cleavage plane. Small cell carcinoma arise from the neuroendocrine cell. In ulcerative colitis, UC is the ulcerative colitis, inflammatory bowel disease. You get the poorly differentiated infiltrative adenocarcinoma with the exophytic growth pattern. So there is the poorly differentiated carcinoma which will be infiltrating deep into the layer up to the serosa and with the exophytic growth or large growth at the mucosal level. This is which side, right or left? Yeah, which side it is?
In the left, maybe?
Yeah, it is left because you see it is encircling entire loop of the lumen. Okay, so and this is going deep inside, and this patient might have obstruction. You might see a small polyp here and there. So clinical feature, the condition tend to be present for a considerable time before producing any symptom. So when you get a symptom in colorectal carcinoma, by the time disease is already progressed to a considerable level. Left-sided lesion tend to be present earlier, but also have a more infiltrative growth pattern and a poor prognosis. Why? Because it goes deep into the deeper layer and it can go to the serosa and it can even come into the peritoneal cavity. Okay. So what are the symptoms? Alteration of the bowel habit, constipation, diarrhea, bleeding per rectum, loss of weight, lower and lower iliac fossa, lower abdominal or left iliac fossa abdominal pain. Right-sided lesion tend to present with weakness, malaise, weight loss, unexplained anemia secondary to the early bleeding, mass in and the pain in the right iliac fossa. So here the bleeding will be minimal. So you will not see the fresh blood or bleeding per rectum. Here you might see the occult blood in the stool. So you need to see the stool for the occult blood. Frank bleeding will not be visible in the early cases of the right-sided lesion. If the right-sided lesion is very large, very big, invade a big vessel, you might see the frank bleeding. But bleeding per rectum is more common with the left lesion, while the occult blood present in the stool is more common with the right-sided, and anemia is also very common in the right-sided because this patient will have a prolonged loss of blood. A small amount of blood is losing in the stool and patient is not knowing. He usually come with the severe weakness, tiredness, and when you examine you see the severe pallor and you ask for the occult blood in the stool, you see it result comes positive. And then you go for the colonoscopy and you see the ulcerated fungated mass in the right side of the colon. So clinical feature, right colon usually have diarrhea, anemia, left colon constipation, bleeding per rectum, and you if the tumor in the rectum, usually you have the alternate diarrhea, constipation, tenesmus. Tenesmus is uh, pain while passing the stool. And you might also see the blood and mucus discharge. Spread of the colorectal carcinoma, it directly extend If it is in the ascending colon, it can go down to the cecum, go up to the uh, transverse colon, or in the sigmoid to the rectum, rectum to the anal canal. It also passes through the mucosa to the submucosa, to the muscularis, to the serosa. It also go through the lymphatic to the lymph nodes, through the blood vessels to the liver, lungs, and bone. And you have one marker, serum level of carcinoembryonic antigen. They are very, very well correlated with the size and the metastasis. And if you see very high level of CEA, you might see your patient has a large tumor, and there is also a chances of metastasis. This tumor marker will not play much role in the diagnosis, but they have a very important role in the prognosis, especially monitoring your patient after a surgical resection. You have treated your patient with the help of uh, colectomy, you give him chemotherapy, and you give him radiotherapy. You label your patient as the disease-free or cancer-free, but you need to follow him up with the CEA level. If the CEA level is normal, undetectable, it means your patient is cancer free. But this level started to raise or reappear, it means the tumor has recurred or there is metastasis at a different site. Now we go to the staging of the tumor. Staging, you have two methods. British people usually go for the Duke staging, and this is Duke A, B1, B2, C1, C2, and D. A, tumor is only in the mucosa. B1, tumors have in up to the muscles, but not completely. B2, tumor has involved the serosa also. So all the layer from mucosa, the serosa is involved, you see is the B2. Only the mucosa and muscularis, it is B1. Only the mucosa, it is A. C1, tumor involve the muscle wall, but not completely. Local lymph nodes are involved. Okay. So B1 along with the lymph nodes, it is called C1. B2 along with the lymph nodes, it is called C2. And D is the distance metastasis. This is very, very important. You get a lot of questions in this exam, as well as in your year 5 surgery, year 6, as well as in the assembly. So A, B1, B2, C1, C2, D. So A is the mucosa. B is going into the, there is some problem with this picture, okay? So don't go with this pictures. A is just to the mucosa. B1 or B1, B2, if it is up to the muscularis, it is B1. It goes to the serosa, it is B2. C1 with the regional lymph node, C2 entire layer with the regional lymph node, D is always with the distance mechanism. So you have, why do you do this staging? Because you can expect the prognosis and survival. If your patient is limited to the submucosa and mucosa, your patient survival is 90 to 95%. B1, 90. B2, 75. C1, 1 to 4, more than 4, 65, 42. And D, if it, even the tumor is seen in the mucosa, but you see the distant metastasis in the liver, the prognosis drastically reduced from 90 to 5%. This is about the AJCC, American Joint Committee on the Cancer Classification. American, and even for the Saudi Arabia, they prefer AJCC classification. It mainly depends on the T and M staging: tumor size, nodal metastasis, and distant metastasis. T for tumor, N for lymph nodes, and M for the distance metastasis. Okay. So TX, when the primary tumor cannot be assessed. T0, no evidence of the primary tumor. TIS carcinoma in situ or just into the mucosa, not has infiltrated the mucosa. Okay. T1, tumor invade the submucosa through the muscularis propria, but not into the muscularis mucosa, but not into the muscularis propria. T2, tumor invades muscularis propria. T3, tumors go into the pericolorectal tissues. T4, it goes to the peritoneum. Okay, visceral peritoneum and other structure like cervix, uterus, or bladder get attacked equal T4. And X, we don't know what is the lymph node involves or not. N0, no lymph nodes, lymph nodes. N1, 1 to 3 neural, N2, 4 lymph nodes, 4 or more. M0, no distant metastasis. M1, distant metastasis. So this T1, T2, T3, T4, N1, only 3, and N4, 4 or more. This is the stages 1, stage 0, stage 1, stage 2A, 2B, 3A, 3B, 3C, 4. This is very, very, very important. You read it and understand on yourself, okay? Because I tell it will not go into your mind until unless you read on yourself. If you get any doubt, please ask me through my WhatsApp or you can call me, but please do read it. It is very important slide. So how do you diagnose? The most important diagnosis come from the colonoscopy and the biopsy. But you have under supplementary tests as CBC to assess anemia, occult fecal blood analysis, especially it is a very important tool for the screening in the general population, colonoscopy, biopsy, tumor marker, you go for the CEA. It is very important for the prognosis. Before surgery, if you see the very high amount of CAA, you can call it as a large tumor and there is metastasis. But after surgery, it should be less than 5 nanogram. If you see more than 5 nanogram, it means your tumor has recurred or there is metastasis. You also do the US abdomen CT, MRI, PET CT. This is very important for the staging. Especially PET CT and MRI and CT will tell you whether the tumor is localized or have spread to the distant organ. Treatment, you have surgery, you have left hemicolectomy, subtotal colectomy, right hemicolectomy. So hemicolectomy is you are removing a part of the colon, more like approximately half part of the colon. Right? There's the left side and the right side. Subtotal, it goes from cecum, appendix to the sigmoid colon. Chemotherapy, you have adjuvant after surgery to kill, neoadjuvant before surgery as well as after surgery. You have targeted therapy, a lot of studies going on to research on the gene, if you can target any of the genes and stop the treatment. So with the help of targeted therapy, chemotherapy and the radiotherapy, you can very easily to kill the cancer cell. But the challenge is to keeping the patient alive at the same time, because these treatment not only kill the cancer cell, they can also kill the normal cells also. And they make your patient more prone to the infection, organ failure, sepsis, rather than tumor. Most of the time patient die because of the complication of these treatment. So you have to go very judiciously, you think very cautiously, so you only kill the cancer and you patient survive. So this is, thank you for 2 lectures for your patience hearing and your attention. If you have any doubt, please feel free to ask me.